Welcome to Mastering the Gut, Bridging the Lab Gap. Unit 1, Erythrocyte Morphologic Analysis. During their 120-day lifespan, red blood cells repeatedly traverse the capillaries of the vascular beds and endothelial slits of the spleen, both of which are narrower than their smallest dimension. This necessitates the ability of the red blood cells to undergo repeated, extensive, and reversible deformations. Repeated membrane deformations induce ion and water permeability changes in the red blood cells. Impaired red blood cell deformability, which occurs with inflammation, shifting pH, and altered blood chemistry, contributes to the development of multiple organ dysfunction syndromes by impairing tissue microvascular blood flow. The severity of the loss of red blood cells' ability to carry oxygen is directly related to the extent of the membrane surface area lost. Erythrocytes have a distinctive biconcave disc form. It has been suggested that this shape maximizes the surface-to-volume ratio and thus expedites diffusion throughout the body. Maximal diffusion occurs in small vessels. In order to pass through the microvasculature, the erythrocyte becomes distorted and deviates from the biconcave disc shape. Erythrocyte deformability refers to the ability of the erythrocyte to change shape under a given level of applied stress without rupturing. This is an important property because erythrocytes must change shape extensively under the influence of mechanical forces in the blood flow and while passing through the microcirculation. The age of the blood cells is also important when considering the rheologic properties of the circulating erythrocytes. The shape change of the erythrocytes under applied forces is reversible, as long as it's healthy, and the biconcave shape is maintained after removal of the deforming forces. In other words, erythrocytes behave like an elastic body, while they are resisting shape change under the deforming forces. The viscoelastic behavior of the erythrocyte is determined by the three following properties: geometry of the erythrocyte, cytoplasmic viscosity, and viscoelastic properties of the erythrocyte membrane. I ordered a lab test for a person who is reporting multiple symptoms: brain fog, fatigue, lack of energy. I don't feel good. People tell me I look too good to feel that bad. When the lab results come in, the labs are within normal or functional ranges. Some of the markers may be towards the top or bottom of the normal range, but nothing was seriously out of range. How can this person be reporting all these symptoms with nothing out of range? Well, there are several concepts to understand. Lab tests are about probabilities, not absolutes. An illness is but one constitutional disease. No part of the body can be understood separate from the whole. A complete blood count, or a CBC, gives us important information about the kinds and numbers of the cells in the body, especially red blood cells, white blood cells, and platelets. However, it gives very little information as to the actual shape of the red blood cells. Many of the red blood cell deformities are reported in the red blood cell test results. This unit will help you identify their possible presence using the red blood cell indices. Red blood cells carry oxygen from the lungs to the rest of the body. They also carry carbon dioxide back to the lungs so it can be exhaled. The release of ATP from red blood cells occurs in response to small changes in pH, oxygen concentration, or osmotic pressure. Physiologically, erythrocytes release ATP in response to mechanical deformation, as would be encountered when the cells traverse the microcirculation. If the red blood cell count is low, as in anemia, the body may not be getting the oxygen it needs. There is also a chance that the red blood cells will clump together and block the tiny blood vessels. This makes it hard for the red blood cells to carry oxygen and keep the tissues oxygenated. Hematocrit measures the amount of space or the volume the red blood cells take up in the blood. The value is given as a percentage of the red blood cells in a volume of blood. For example, a hematocrit of 38 means that 38% of the blood's volume is made up of red blood cells. Hematocrit and hemoglobin values are two major tests that show if anemia is present. The hemoglobin molecule fills up the red blood cells. It carries oxygen and gives the blood its red color. The hemoglobin test measures the amount of hemoglobin in the blood and is a good measure of the blood's ability to carry oxygen throughout the body. There are three red blood cell indices: mean corpuscular volume, MCV, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration, MCHC. These are measured by a machine, and their values come from the measurements in a CBC. The MCV shows the size of the red blood cells. The MCH value is the amount of hemoglobin in the average red blood cell, and the MCHC measures the concentration of hemoglobin in an average red blood cell. These numbers help in the diagnosis of different types of anemia. Red cell distribution width, RDW, can also be measured, which shows if the cells are all of the same size or different sizes and shapes. Platelets, or thrombocytes, are the smallest type of blood cell. They are important in blood clotting. They also store the majority of the serotonin in the body. And when bleeding occurs, the platelets swell. Serotonin is released to constrict the blood vessels, allowing platelets to clump together and form a sticky plug that helps stop the bleeding. If there are too few platelets, serotonin may be a problem with this person. The body always moves towards homeostasis. Even in cancer, the body will be in a state of homeostasis. It's not a healthy homeostasis, but it is in a state of homeostasis with the pathology or multiple organ dysfunction occurring in their body. During this process of achieving homeostasis, red blood cells become damaged and change shape. This change in shape can only be seen with a peripheral blood smear or live cell analysis using a dark field microscope. The deleterious nature of turbulence while in the cardiovascular system suggests that the biconcave disc has evolved out of necessity to maximize laminar flow, minimize platelet scatter, which in turn suppresses the atherogenic activity in the large vessels. The biconcave profile of the discocyte means that much of the mass is distributed in the periphery. This increases the movement of inertia of the cell and subsequently renders the erythrocyte less prone to rotation during flow in the large vessels. This reduction in rotation promotes laminar flow and discourages platelet scattering by minimizing the eddy currents and is thus anti-atherogenic. A number of dysfunctional mutations results in the blood cells contorting into different shapes as opposed to the biconcave disc profile. These different shapes have a smaller moment of inertia when compared to the discocyte, as much of their mass is distributed around the center, rendering the dysfunctional erythrocyte more prone to rotation during flow in the large vessels. There is no specific barrier to oxygen diffusion in the blood vessels that prevent oxygen from exiting the blood cell or the vessel itself. oxygen delivery to tissues depends on the oxygen carrying capacity of the blood, its conveyance from the lungs to the tissues, and the mechanisms that control its release and uptake from the blood. In circulation, there is no specific signal for oxygen diffusion in the blood vessels that prevents oxygen from exiting the blood cell. As a consequence, oxygen continually diffuses out of the blood vessels, and the transient velocity of the red blood cell determines its release location within the circulatory system, in the same way that the delivery of fluid transported from a leaky container is a function of the container's velocity during transportation. The competition between the blood flow velocity and the outward diffusional exit from circulation determines the oxygen saturation in the location in the circulation where the blood oxygen is released. There is no guarantee of oxygen delivery by red blood cells. There is no tracking number, no special delivery. Millions of times during their 4-month lifespan, human red blood cells must squeeze through tiny capillaries to deliver their payload of oxygen and pick up waste carbon dioxide, both functions essential to life. Blood cells must rearrange components of their internal scaffolding, the so-called cytoskeleton, allowing the cells to become almost liquid-like in order to squeeze through the narrowest capillaries found in the body. Erythrocytes that are deformed, infected, damaged by inflammation, and hemoglobin-deficient red blood cells are incapable of proper oxygen transport. There are numerous conditions that account for the oxygen deprivation due to damaged red blood cells experienced by various tissues of the body. Impaired red blood cell deformability, which occurs in sepsis, after trauma, and during shock states, contributes to the development of multiple organ dysfunction syndromes by impairing tissue microvascular blood flow. Healthy pliable red blood cells are able to change their shape, allowing them to move into capillary beds, providing oxygen to tissues and carrying carbon dioxide away. The release of ATP from red blood cells occurs in response to small changes in pH, oxygen concentration, or osmotic pressure. Physiologically, erythrocytes release ATP in response to mechanical deformation, as would be encountered when these cells traverse the microcirculation. Extracellular ATP is known to inhibit growth of breast and lung tumors and play a role in inflammatory responses to wounds. Impaired red blood cells deformability, which occurs with inflammation, shifting pH, and altered blood chemistry, contributes to the development of multiple organ dysfunction syndromes by impairing tissue microvascular blood flow. There is a significant impact of diffusional oxygen loss on the distribution of oxygen in downstream vessels during changes in red blood cell deformability, altered vasomotor control, and blood chemistry. Decreased deformability inhibits the movement of red blood cells into capillary beds. The turbulence created at the entrance to the arterioles by the stiffened red blood cells causes them to release their oxygen. The oxygen diffuses into the arterioles, causing tissues to be hypoxic and hypercapnic. Erythrocytes release their ATP in response to the combined effects of hypoxia and hypercapnia. Red blood cell exposure to reduced oxygen tension alone is sufficient to stimulate ATP release from the erythrocytes. A variety of diseases are linked to impaired ATP release from red blood cells, including cystic fibrosis, pulmonary hypotension, and diabetes and insulin resistance. In this graphic, the higher oxygen saturation is found along the vessel centerline, designated by the bright red erythrocytes. The erythrocytes with the lower oxygen saturation near the arterial walls are purple. In Figure A, vasoconstriction of the side branch reduces both hematocrit and oxygen saturation in that vessel. The lower hematocrit and oxygen saturation near the arterial walls results in the distribution of red blood cells and oxygen into the side branch, which is not proportional to the blood flow as shown in Figure B, while vasodilation in Figure C increases both hematocrit and oxygen saturation moving into the side branch. There are several specific mechanisms that affect the number of capillaries with compromised red blood cell flow. These are capillary lumen narrowing beyond the point where capillary pressure can provide the energy needed for red blood cell deformation, capillary luminal obstruction by white blood cells and platelets with rigid red blood cells, hydrodynamic effects at the capillary bifurcations which direct red blood cells to stream with the greater flow. Pathophysiologic conditions such as ischemia and oxidative stress may impair the endothelial function, interfering with local capillary regulation, causing endothelial swelling, increased endothelial tone, and increased capillary permeability, promoting pericapillary edema. Areas of high turbulence in the vasculature accelerate the release of oxygen from hemoglobin. This occurs in the heart, bifurcations or junctions of the arterioles. The increased release of oxygen in ATP results in agglutination and Rouleaux formation of the red blood cells, further depriving tissues of needed oxygen and energy. When blood flow stasis is induced through vasoconstriction, adhesions, or physical strictures, red blood cells aggregate to form rouleaux. These aggregations continue to enlarge as long as stasis or diminished blood flow occurs. An example of this is adhesions compressing blood vessels. On resumption of normal blood flow, the Rouleaux formations break up and disperse, returning to their original individual erythrocyte status. A high flow velocity can stop the formation of Rouleaux. As seen in the CBC results, a high hematocrit level can promote red blood cell aggregation and Rouleaux formation. However, after the Rouleaux have been formed and then dispersed, the aggregation and turbulence surrounding the red blood cells has accelerated the release of the oxygen and ATP, making the red blood cells hypoxic until the next passage through the lungs. In the presence of fibrinogen, accumulation and adhesion of leukocytes to the epithelial cells of the blood vessel walls increases dramatically due to the Rouleaux formation. This enhances the radical migration of white blood cells. At modest levels of red blood cell aggregation caused by the increased fibrinogen, greatly enhanced migration and enhancement of adhesiveness synergistically promote firm white blood cell endothelium adhesion in a low flow state. Rouleaux may dissociate either due to the presence of externally applied forces, such as shearing stresses, or due to the chemical bonds involved in the macromolecular bridges holding the erythrocytes together within a Rouleaux formation, which eventually break. As a practical matter, under conditions which cell-to-cell interactions are sufficiently strong to produce a Rouleaux formation, spontaneous degeneration is rarely, if ever, observed. The balance of the body's electrolytes is referred to as the zeta potential. When we have too much or too little of some electrolyte, an imbalance often results. The slight negative charge drifts towards neutral, and blood, lymph, stool, urine, digestive chemistry, and other body fluid ingredients become sticky. In a general way of thinking, which is oversimplistic, think of anions as dispersers and cations as coagulators. Further, you could say anionic leans alkaline, cationic leans acid. Think of it this way. Anions disperse things, cations bring them together, or alkaline disperses and acid brings them together. Well, what is zeta potential? The health of living cells under normal and pathologic conditions is reflected in the zeta potential of the cell surface charge. The cell surface charge depends on the composition of the cytoplasmic membrane and the physiologic condition of the cells. All of life moves about with a constant interplay between the forces of the ions. Ions are electrically charged atoms or groups of atoms. Anions are negatively charged ions and are created through an electron gain, and cations are the positively charged ions created through an electron loss. The electrostatic charge around a colloidal particle, for example, a red blood cell, is known as the zeta potential. In the human body, many think of blood, lymph, urine, digestive chemistry, and the fecal material as a fluid, but it is more akin to a suspension. Solid particles are suspended in a liquid. Each colloid carries a like electrical charge, which produces a force of mutual electrostatic repulsion between the adjacent particles. If the charge is high enough, the colloids will remain separate, dispersed, and remain in suspension. Reducing or eliminating the charge has the opposite effect. The colloids will steadily agglutinate and settle out of suspension or form an interconnected matrix. In the colloidal chemistry of the human body, blood, lymph, urine, digestive chemistry, and chyme could easily be thought of as nothing more than a colloidal slurry. This relates to the electrical charge around the colloid in suspension. The blood, lymph, urine, digestive chemistry, and chyme are controlled by pH and all the other elements found in the soup along with it. The principles that apply to any colloidal slurry or suspension also apply to the soup. When tiny minerals or organic particles, also known as colloids, are suspended in a fluid, the negative ionic charge around the colloid is what maintains the dispersion or the discreteness of the particles of the suspension. If the zeta potential is low or high, enzymes are unable to denature proteins. Toxins cannot be suspended for elimination. Nutrients cannot be suspended for absorption or transport to the cell. Antibodies are able to make contact with healthy tissue or other elements in the slurry. An example of this is that for proper elimination of waste or elements conjugated by bile, they must remain in a suspension through the small intestine and most of the large intestine, where at that point these elements need to settle out of the mix into the fecal material for elimination. The small intestine is an alkaline environment, whereas the bacterial fermentation shifts the large intestine to an acidic environment. In an unhealthy patient, the zeta potential of the blood is often altered. The shifting of the zeta potential contributes to malformed red blood cells, such as dacrocytes, echinocytes, or acanthocytes. This also allows for the agglutination of red blood cells, either in pairs or even larger groupings, as shown in this graphic. While the automated cell counters are fast, convenient, and precise, certain conditions can interfere with the machine's calculations and result in spurious or erroneous results, simulating a symptom or a condition without being pathological or morphologically genuine. It is important that clinicians become familiar with the more common cause of these spurious results with the electronic counters. Circulating cells, including red blood cells, white blood cells, and platelets, are counted and sized electronically by these modern instruments. One such instrument, the Coulter counter, generates an electric pulse when a blood cell passes through a small aperture surrounded by electrodes. Each electronic pulse represents an individual cell, and the pulse height indicates the cell volume. Therefore, the electronic counter not only registers the total cell count, but also estimates the average cell volume and the variations in cell size. Automated cell counters may produce abnormal values, as the agglutinated cells may be counted as single cells, while the larger groups of agglutinated cells are not counted at all. It is important to identify abnormal red blood cells when patient lab tests do not match their symptomatology. There may be one or more red blood cell irregularities seen on a peripheral blood smear or live cell analysis. Two examples include anisocytosis, which is variable sizes of red blood cells, which indicates anemia. These red blood cells are smaller than normal and are referred to as microcytes, and red blood cells larger than normal called macrocytes. The other example is poikilocytosis, and these are various shapes of red cells that may include echinocytes, acanthocytes, elliptocytes, keratocytes, Rouleaux, sickle cells, target cells, teardrop cells, stomatocytes, and schistocytes. There are two methods of identifying these abnormal blood cells: peripheral blood smear and live cell analysis. A blood film or peripheral blood smear is a thin layer of blood smeared on a microscope slide and then stained in such a way to allow the various blood cells to be examined microscopically. The live blood analysis, or live cell analysis, or nutritional blood analysis, is the use of a high-resolution dark field microscope to observe the live blood cells. When is a peripheral blood smear or live cell analysis ordered? The peripheral blood smear is primarily ordered to evaluate blood cells when a CBC with differential performed with an automatic blood cell counter indicates the presence of abnormal or immature cells. It may also be performed when a person has signs and symptoms that suggest a condition affecting blood cell production or lifespan. Examples of signs and symptoms that may indicate one of these blood disorders include weakness, fatigue, pale complexion, unexplained jaundice or liver symptoms, fever, excessive bleeding periods, easy bruising or frequent nosebleeds, enlargement of the spleen, bone pain mimicking sciatica. The reason the blood is stained in a peripheral blood smear is that the sicker the patient is, the quicker the blood deteriorates. Live cell analysis allows the deterioration to be visualized. Initially, the blood cells in the live cell image will appear visible and easily identifiable. However, as the blood begins to deteriorate, the image will be blurred by fibril formation. An example of this occurred with a patient suffering from liver cancer that was being supported by my office. Their live cell samples started out looking normal, but within seconds deteriorated. The fibril formation looked like cracking glass special effects from a movie, after which the slide was completely muddled. Live blood cell analysis is promoted by some alternative medicine practitioners who assert that it can diagnose a range of diseases. However, a quick review of YouTube videos will demonstrate multiple explanations of the same cell type or object in the image, making it very questionable. Another example of this is a traveling live cell technician visiting my office identified everyone as having uric acid crystals and parasites. This motivated me to obtain a microscope and certification training. During the first 5 minutes of the class, the instructor places a clear slide on the microscope. He finds a crystal on the slide and asked what it was. Everyone, including myself, said that it was a uric acid crystal. Then he reminded us that there was no blood on the slide. It was a shard of glass. The parasites the technician was identifying were proteins in the blood moving through Brownian motion under the influence of the zeta potential in the plasma. For the purposes of this program, live cell analysis is useful only in the identification of blood cell morphology and the time in which the blood sample decays. The advantage of the live cell analysis allows for the visualization of the granules within the leukocytes and their movement throughout the sample, indicating the health of the immune system. Bacteria and microbes can be visualized but not identified. Emphasis must be made that PCR testing is the best method of identification of microbes. Visualization of microbes through live cell analysis is not conclusive, as microbes are pleomorphic and change their shapes outside of their preferred environment. This concludes Part 1 of Bridging the Lab Gap, CBC Morphology. Thank you for watching Mastering the Gut. Altered structure causes altered function. You may take the quiz and move to the next section.